All right, welcome. This is your practical clinical update on managing community-acquired pneumonia, or CAP. Think of this as your playbook. We're going to build it out with the most current, high-impact info that you can start using at the counter today.
So let's get right into building that playbook. We're going to focus on the essential updates, picking the right therapies for the right patient, and, probably most important, the exact counseling points you can use to make a real difference.
First up, let's do a quick refresher. When that CAP prescription hits your counter, what are we really looking at? Having a solid foundation just makes everything else, especially the prescriber's choices, make a lot more sense.
Now, as you know, CAP is a really common and serious illness. And yeah, about 80% of cases are managed at home, but we have to take it seriously. Mortality rates can jump up to 10% for those who need to be hospitalized, and it gets even higher for patients in the ICU.
Okay, check this out, because this is fascinating data from hospitalized patients. We always think of Streptococcus pneumoniae as the big bad bacterial culprit, right? But look, viruses like rhinovirus and flu are right up there. But the biggest slice of the pie? 60% of the time, no specific pathogen is ever found. And that is exactly why our empiric therapy choices are so incredibly important.
Next, let's talk severity. Understanding these scoring tools gives you that critical context for the prescription sitting in your hand. It's the why behind the what. It's how prescribers decide between sending a patient home with a script or sending them straight to the hospital. So what this really boils down to is that these scores directly shape the prescription you're about to dispense. If the score is low, you're probably looking at a script for oral amoxicillin. But if that score is high, well, that patient is in the hospital, likely getting IV ceftriaxone. It's the roadmap for the entire therapy choice. And here are the two main tools they're using. On one side, you have the Pneumonia Severity Index, or PSI. It's pretty detailed and helps guide that decision to hospitalize. A score of 90 or less usually points toward outpatient care. Then on the other side, you've got CURB-65, a much simpler, faster tool that quickly predicts mortality risk based on just 5 key clinical signs.
So this brings us right to the heart of it all, the treatment. What are the go-to empiric therapies according to the latest guidelines? And, just as important, what are the absolute must-know warnings that you need to have on your radar?
For most of your otherwise healthy outpatients, the guideline is super clear and simple. High-dose amoxicillin is the preferred first choice. If that's not an option, maybe due to an allergy, doxycycline is a solid second choice. You can see this major push to use targeted narrow-spectrum agents first.
And this is absolutely critical to remember. Respiratory fluoroquinolones are not first-line agents anymore. This is a huge stewardship point. We need to reserve them for very specific situations, not only to limit resistance, but also to avoid their really significant adverse event profile.
Okay, now I need everyone to really tune in for this one. This is a critical safety alert about MRSA pneumonia. This is a scenario where your intervention as a pharmacist is absolutely essential to prevent a major therapeutic error. So here it is. If you ever see a prescription for daptomycin that's intended for pneumonia, that is a massive red flag. You have to intervene immediately. The drug is literally inactivated by the lung's own surfactant, making it completely useless. This is a piece of knowledge that can absolutely protect your patient.
And what about how long to treat? Well, the magic number to remember is 5. For uncomplicated CAP, patients need a minimum of 5 days of therapy. You have to remind them to complete the full course, even if they start feeling a lot better on day 2 or 3.
All right, let's shift gears to one of the most vital things we do as pharmacists, patient counseling. This is truly where we can make the biggest difference in adherence, in safety, and ultimately in patient outcomes.
So when you're dispensing a macrolide, and you'll still see them, especially in combination therapy for sicker patients, there are a few key areas you absolutely have to cover to keep your patients safe.
Okay, so for macrolides, your focus needs to be on the risk of QTc prolongation. You got to tell patients to watch for things like dizziness or feeling like their heart is racing. Mention the GI upset for sure. And with clarithromycin specifically, you have to review their med profile for those big CYP3A4 interactions, especially with common drugs like atorvastatin or simvastatin.
Now, for the respiratory fluoroquinolones, well, the counseling is a lot more extensive, and it carries some really significant warnings that every single patient needs to hear directly from you. Your mental checklist for these has to be thorough. Start with the big one, the black box warning. Tell them about the risk of tendon pain or rupture and to report any new joint pain immediately.
Next, warn them about photosensitivity, wear sunscreen. And of course, the classic point we all know, they have to separate the dose by at least 2 hours from any antacids, iron, or calcium supplements.
And finally, let's talk about our most common first and second line agents. The counseling here is more straightforward, but it's no less important for making sure the medication works safely and effectively.
With doxycycline, there are 2 huge points. Warn them about that photosensitivity and tell them to take it with a full glass of water while sitting upright to prevent that nasty esophageal irritation. For amoxicillin/clavulanate, GI upset is super common, so definitely recommend taking it with food. And for any beta-lactam, it should just be automatic. Always, always, always confirm their penicillin allergy status.
Beyond just treating infections after they happen, our role in prevention is just paramount. So let's look at the key strategies where you can make a huge impact on the health of your community.
This slide really shows a major shift in our vaccination strategy. Basically, we've moved on from the older polysaccharide vaccine, Pneuma 23. The new standard of care is the conjugate vaccines, the PNU C20 and 21. Why? Because they trigger a much more robust, durable, and potentially lifelong immune response. This is a vital conversation you should be having with all your eligible adult patients.
And please, always remember this incredibly powerful fact. Smoking literally doubles a person's risk for invasive pneumococcal pneumonia. Encouraging and supporting smoking cessation is one of the single most effective preventative health interventions you can be a part of.
And that brings our clinical update to a close. So as you get back to your practice, I want you to think about this. Which one of these takeaways, maybe it's that daptomycin warning or the new vaccine guidelines, or just one specific counseling tip? Which one can you immediately apply to improve care for your very next patient with community-acquired pneumonia?